So this young patient, 27-year-old male, comes to me with complaint of palpitations, more so on exertion, and hands me over his ECG, which was for showing sinus tachycardia, somewhat prominent Q wave in lead 3 here, and somewhat prominent R wave in lead V2. I asked nurse to get his vital. As soon as I look at his vital, I get worried as he was hypotensive with BP of 90/50, and he was hypoxic with saturation of 91% at room air. He was still tachycardic and was also having tachypnea with respiratory rate of 32. Next, I ordered his new ECG. As soon as I look at this ECG, I thought he might be either having cardiac ischemia or he might be suffering from pulmonary embolism. So, what things suggest that he might be having pulmonary embolism? First of all, if you look at lead 3, you will see that this here is Q3T3 pattern with sinus tachycardia, more commonly seen in pulmonary embolism. While when you look at precaudally, specifically anterior leads, there is T wave inversion with prominent R wave in lead V2 here. So I ordered his chest X-ray to rule out any lung pathology. Here is X-ray of this patient. In this X-ray, there is prominent right pulmonary artery with somewhat increased shadow of right heart. Next, we got his echocardiography. In this echocardiography, we found that he was having septal paradox, dilated right ventricle with preserved systolic function, and mild moderate tricuspid regurgitation with moderate pulmonary hypertension. All these changes were suggestive of and pointing towards pulmonary embolism. Next, we needed to do CTPA to determine severity of this pulmonary embolism. Initially, we started him on anticoagulation. We need to do CTPA to determine severity. Here is CTPA of this patient. In CTPA, you will see filling defects in bilateral pulmonary arteries, right and left. Filling defect is usually seen in as a hypodense region on CTPA. I will show you that here this is filling defect in left descending branch of pulmonary artery. I will start this video for you here. So let's now follow this filling defect here. Follow this and you will see that it's in also main left pulmonary artery. Now let's come to the right pulmonary artery. Here there is also a filling defect which comes up to pulmonary trunk. Here is another view of same patient. In this view you can also appreciate Polo-Mint sign. Here pulmonary embolism in bilateral pulmonary arteries, Polo-Mint sign. So why we need to determine severity of pulmonary embolism? The answer lies in management. Whenever dealing with a patient with mild to moderate disease, start them on anticoagulation. But if you find a patient with severe pulmonary embolism or severe disease like this patient, always give such patient thrombolytic therapy like TPA, tissue plasminogen activator, or streptokinase. There is another option which is surgical or interventional, which includes embolectomy. Now, whenever you find a patient with pulmonary embolism, categorize disease severity and always try to look for cause of pulmonary embolism. Let's discuss cause of pulmonary embolism in some other video. Thank you.